Dear colleagues and friends, welcome to this webinar on systemic treatment in muscle-invasive and metastatic bladder cancer. My name is Twan van der Heijden and I'm a uro-oncologist at Radboud UMC, Nijmegen, the Netherlands. And I'm the chair of the EAU Guideline Panel on muscle-invasive and metastatic bladder cancer. And together with the European School of Urology, we have organized this section to provide an up-to-date overview of systemic treatment strategies of this evolving field. And it's my pleasure to introduce you to three very distinguished experts, and they all three are members of the EU Guideline Panel, and they will share their insights today. So we will begin with an overview of the current perioperative systemic treatment options presented by Professor Anja Lorch. She is a professor of medical oncology and head of the uro-oncology department at the University Hospital in Zurich in Switzerland. And next, Professor Matt Milowski will discuss the systemic treatment in metastatic setting. He is professor of urology at the University of North Carolina, the School of Medicine in Chapel Hill, and he's also the co-director of the uro-oncology program at the UNC Lineberger Comprehensive Cancer Center. And last but not least, we will look ahead at future perspectives in systemic treatment with a presentation of Professor Richard Katomas. He is professor of medical oncology and head of the division of oncology and hematology at the Kantonsspital in Graubünden in Chur in Switzerland. Let's begin. Anja, may I hand over to you to give that overview of perioperative systemic options?
Thank you, Twan, for the kind introduction, and welcome also from my side to this webinar. It's my pleasure to start with the first talk. As you already heard, I will give you an overview of the current perioperative systemic therapy. Here are my disclosures first. And what does this mean? I will talk about muscle-invasive local bladder cancer, T2 to T4 N0 M0 localized disease. And I will start with a patient, 72 years old, in a relatively good performance status, smoking history, hypertonus, but very well controlled by oral medication. He presented with painless macrohematuria, and the picture below shows huge local muscle-invasive bladder cancer. His kidney function is with a GFR of 63, relatively normal, a little bit slightly increased LDH, staging with CT of the abdomen and lung showed a local lymph node 13 millimeter, but not really suspect for lymphnodal disease and no further abnormalities. And the biopsy that was done, actually, I said that already, showed muscle-invasive urothelial cancer CT2 to 3. So what's the background about when do we see patients with muscle-invasive bladder cancer localized? About 20% present initially actually as local muscle-invasive cancers and and this is still the gold standard, treated with radical cystectomy. And here, plus or minus perioperative systemic therapy, depending on several factors that you will have or that I will present within the next minutes. 30% actually had superficial non-muscle invasive bladder cancers that eventually become muscle invasive or actually metastatic disease. And what is the problem in localized muscle invasive bladder cancer? About half of the patients will eventually recur with metastatic disease. And why is that? Because of lymphnodal micrometastasis. So there's need for improvement, and that's why we not only do surgery, but we discuss perioperative treatment in those patients. And what are the options we have in such a patient I presented you? I will go through the options, and we'll start with neoadjuvant chemotherapy or NAC alone. And here we all know that cisplatin in combination with, for example, gemcitabine, or as you can see with the so-called MVAC scheme, must be given. So you cannot avoid the cisplatin. You have to give the cisplatin because it's the most effective drug in this scenario. And compared to cystectomy alone, there was a significant benefit with having neoadjuvant chemotherapy up front. There is a new trial, a phase 3 trial that was presented recently. It's the FESPA trial. The French colleagues performed this trial very well. They included also adjuvant patients having had chemotherapy, but the majority had been neoadjuvant. And what did they do? They compared cisplatin with the dose-dense MVAC, and gem-cis have been 4 cycles, whereas 6 cycles of dose-dense MVAC had been given to patients. And what they saw was that the more intensive dose-dense MVAC was superior over the gem-cis chemotherapy. Also, and you see that below, concerning the pathologic complete remission rate, which is a very important prognostic factor, and the dose-dense MVAC population had a higher pathologic complete response rate after having had surgery. Actually, the 2-year progression-free survival and also the 2-year overall survival was superior in the dose-dense MVAC group. But to mention, patients having this treatment, they must be very fit. They must have a very good performance status. And even though it was difficult also in the trial to give the 6 cycles of the dose-dense MVAC, most patients got only 4 cycles. So to give neoadjuvant chemotherapy, this requires adequate renal function. But in all trials that have been performed, there was a significant overall survival benefit with a benefit of 5 to 7 years of better survival after 5 years. The FESPA trial is superior to the often used gemcitabine cisplatin, but could only be given in very fit patients. Otherwise, use the gemcitabine cisplatin, but, and this is what is still not done regularly, do use neoadjuvant chemotherapy. You can use it as a split dose as well. It's helpful in some patients, especially in those with a kind of borderline kidney function. And as I said, pathologic complete remission is associated with improved outcomes, but lots of eligible, cisplatin eligible patients did still not receive neoadjuvant chemotherapy. So what about adjuvant chemotherapy? Data are less good. There are meta-analyses, there is a trial, but compared to neoadjuvant chemotherapy, this is less good data, and it was used in the past if a patient had not neoadjuvant chemotherapy and had a T3, T4, and or N+ stage. But Actually, in bladder cancer, this is not commonly used anymore, whereas in upper tract patients, it is still a valid option. There is a POUT trial, a phase 3 trial that shows that in upper tract patients, chemotherapy given as adjuvant treatment improves overall survival. I move on to adjuvant immunotherapy as monotherapy. Also performed in trials. There are 3 trials with 3 drugs. The IMvigor 010 trial with the atezolizumab, the Checkmate 274 trial with nivolumab, and the Ambassador with pembrolizumab. Inclusion criteria had been patients having had no neoadjuvant chemotherapy and T3, T4, and/or N+, but they also included patients having had neoadjuvant chemotherapy but did not respond well of it and had still a tumor in the specimen in the surgery specimen after that. So 3 trials, 1 trial was negative. This was the IMvigor 010 trial with atezolizumab. Primary endpoint in this trial was disease-free survival with no benefit shown, whereas the first positive trial was the Checkmate 274 trial with the nivolumab. They had co-primary endpoints with a disease-free survival in PD expression positive and in the IIT population, and there was a benefit in disease-free survival. And at GU ASCO, Matt Milosky presented promising overall survival as well. The third trial was the Ambassador trial with pembrolizumab, also with co-primary endpoints that showed benefit in disease-free survival and also OS, better OS data compared to no adjuvant treatment. And here are the 2 positive trials presented both in the New England Journal of Medicine. The study design was quite the same, but keep in mind in the NIVO trial, it was placebo-controlled, whereas in the Ambassador trial, it was an observation arm, and follow-up is different in those 2 trials, but both showed, as I said, disease-free survival benefit. Here, an update of the nivolumab trial with the disease-free survival and a hazard ratio of 0.70. And at GU ASCO, we saw the overall survival data in favor of nivo with a hazard ratio of 0.70. And what was shown also that especially those patients had significant benefit if PDL expression was greater equal than 1%, so-called PDL1 positive. I will move on to the perioperative treatment, the so-called all-in. So you give neoadjuvant treatment, then you have the surgery, and after that you give adjuvant treatment again. And here the SAKK group with Richard Katoma as the presenter of the data and also the first author in the JCO paper in 2023 was the first group that showed that this all-in concept is effective. Patients with muscle-invasive bladder cancer got all cisplatin gemcitabine 4 cycles and durvalumab as neoadjuvant treatment. then got surgery, and a lot of them got surgery. So a minority did not make it to surgery. It was also shown that surgery was not a problem after chemoimmunotherapy, and patients went on to adjuvant durvalumab 10 times. And the Kaplan-Meier plot for EFS, event-free survival at 2 years, showed 76% of patients with no event, and the overall survival at 2 years was 87%. So very good data. And in addition, also the pathologic complete remission rate was 34%, roundabout that we would have expected also with the GemCis, and a little bit less than seen with the dose-dense MVAC. So this was the first trial showing efficacy of a combination of chemoimmunotherapy as neoadjuvant and adjuvant treatment. And as you all know, there's the Niagara trial, a phase 3 trial using the same drugs as we saw in the SAKK trial, and also randomized, or in this phase 3 trial, randomized patients with muscle-invasive localized bladder cancer into the experimental arm. Patients got the durvalumab gemcitabine cisplatin combination neoadjuvant ×4. The comparator arm got only chemotherapy. Then patients got radical cystectomy, and in the experimental arm, durvalumab was given in addition as adjuvant treatment, whereas in the standard of care arm, no treatment was given. Dual primary endpoints: event-free survival and pathologic complete remission. A key secondary endpoint was overall survival, and of course safety as another endpoint in this trial. And what was seen? There was a significant benefit from the durvalumab chemo group concerning the pathologic complete remission rate, as well as for event-free survival and overall survival. And this benefit was seen across all subgroups, and also this paper was recently published in the New England Journal of Medicine, first author Tom Powell's. And here are the Kaplan-Meier curves, where you can see the orange line with the durvalumab group with the better EFS, and also for overall survival, the orange line over the blue line, which represents the standard of care arm with chemotherapy only. And on the left side, you see a pathologic complete remission rate in this trial of 37% in the durvalumab chemo arm, compared to 27.5% in the chemotherapy arm. So actually, some other analysis have been performed. On the left side, you can see that also in the non-pathologic complete remission group, the experimental arm with durvalumab was superior compared to chemotherapy alone. We see the same with the patients with pathologic complete remission rate. They have overall a better outcome than those with non-PCR. And what we can see as well is that this is a quite well tolerated therapy, so there is no adding toxicity using the durvalumab in combination with chemotherapy. So leading to this continuation is kind of the same in both groups, as well as not those patients not undergoing surgery, which was a very low number. So most patients could have their surgery as planned. And if we talk about toxicity, we talk about the typical chemotherapy toxicity and also the already known toxicity of immunotherapy. But with the combination, there was not more toxicity in those patients. So very well tolerated combination with very good results. And actually, this is now the new standard of care. Perioperative treatment in cisplatin eligible patients should be performed in all of those patients. So the classic only neoadjuvant chemotherapy or the classic adjuvant chemotherapy, immunotherapy, I think is getting more and more less frequently given, and the perioperative treatment will be and is, to my view, already the new standard of care. There are patients that are not willing to lose their bladder, or they are not fit enough, or they cannot get the treatment, and there's an alternative. I want to mention that also. It's the multimodal or so-called trimodal treatment using radiotherapy with a radiosensitizer to preserve the bladder. It's there are data showing that it's also a curative treatment that in selected patients it's not different to only neoadjuvant chemotherapy, and it should be discussed in tumor boards as well. So here are the curves of matched pair analysis. Slaughter et al. Published in the Lancet Oncology in 2023, and you see trimodal therapy provides an oncologically equivalent alternative to resection of the bladder in selected patients. So my conclusions today, perioperative chemoimmunotherapy is the new standard of care in cisplatin and immunotherapy eligible patients. Neoadjuvant chemotherapy alone in cisplatin eligible patients, but immunotherapy ineligible patients should be discussed. Adjuvant immunotherapy alone is still an option in patients not eligible for cisplatin. The resection still is still the standard of care. Radiochemotherapy can be an alternative in selected patients. And what is our goal? We have to define patients who do not need definite treatment of the bladder. Bladder preservance strategies is what I mean here, or that do not need adjuvant immunotherapy anymore, but it is not known which patient is that. So we have a lack of biomarkers, a lack of methods to define clinical CR as well, but this will present it in Richard Katsuma's talk. There are future options, and maybe we can preserve bladder more often or do not need adjuvant treatment. Thank you very much, and I'm happy to take one question now, and after the three talks then in the question and answer section. Thank you very much.
Thank you, Anja, for this excellent presentation. And let's have one question. I was wondering, when you look at the data of the IMvigor 010 trial, there was no disease-free survival benefit for adjuvant atezolizumab, unfortunately. But in the updated overall survival analysis, they took in circulating tumor DNA. And when they studied it, when the patient was ctDNA positive, those patients have a benefit when they are treated with atezolizumab. And I was wondering, what is your opinion about ctDNA in patients treated, for example, with nivolumab? Will that make a difference?
I think ctDNA is getting more and more important to select patients. It's a prognostic factor, but it's not a predictive factor. So has been shown in several trials where they looked for ctDNA. We saw it recently also for the EV plus Pembro trial, or also for the Niagara trial, that those patients starting with ctDNA positive, becoming ctDNA negative, they do better than those staying ctDNA positive. And I think, yes, it's a prognostic factor at the moment. It's not for daily clinical use. It's not still implemented, but this will be done more and more in the future. And then you could select patients together, maybe with the pathologic complete remission rate, to maybe avoid adjuvant treatment, or much before to avoid removing the bladder or local treatment at all. So this could help to define those patients, but for the time being, it's not yet implemented. It's only a prognostic factor so far.
Okay, thank you. Yeah, for bladder preservation, that would be ideal, actually. But let's see. Thank you, Anja. At the end of the webinar, we have some other questions that have raised. We will first proceed now with systemic treatment in the metastatic session by Matt Milowski. Matt, can I hand over to you?
Yeah, absolutely. It's a pleasure to be here and to be able to present some of the really transformative data on systemic therapy in metastatic bladder cancer. And these are my disclosures. So if we think about the timeline of advances in the management of bladder cancer, not much had gone on over the course of many decades, particularly as related to the treatment of patients with advanced disease. There was, of course, the MVAC regimen that was developed in the 1980s, and then the combination of gemcitabine and cisplatin that was initially published in 2000. And the comparative study that was published in 2000 and updated in 2005, comparing GC and MVAC and demonstrating similar survival outcomes with less toxicity for gemcitabine and cisplatin, making it the standard of care over the course of decades. And then came immunotherapy, and immunotherapy has really transformed the management of patients with advanced disease. And so here is one of the first studies that changed the landscape, the Javelin Bladder 100 trial. And this looked at patients with metastatic or locally unresectable disease who received chemotherapy with gemcitabine and platinum for 4 to 6 cycles and randomized to maintenance avelumab or best supportive care. The primary endpoint of this study was overall survival. And as you can see in the Kaplan-Meier curve, there was, in fact, an improvement in overall survival associated with maintenance avelumab with a hazard ratio of 0.69. And this, for some time, became a standard of care to use maintenance immunotherapy. Well, what about combinations of chemotherapy and immunotherapy, or immunotherapy combinations? We've seen this in many other cancers being successful. And there have been multiple attempts in metastatic urothelial carcinoma, including the IMvigor130 study, Keynote 361, the Danube study, and Checkmate 901. Unfortunately, some of the original studies did not demonstrate a significant benefit. However, Checkmate 901, which was initially presented at ESMO 2023, specifically looking in the first-line setting in patients receiving nivolumab in combination with gemcitabine and cisplatin, as compared to gemcitabine and cisplatin alone, demonstrated a significant benefit for the immunotherapy combination. And so here is the schema. Again, Nivo with Gemcis as compared to Gemcis, and there's a Nivo treatment arm after 6 cycles of chemotherapy with nivolumab. And here, again, at ESMO 2023, looking at the overall survival Kaplan-Meier curve with a hazard ratio of 0.78 and the PFS with a hazard ratio of 0.72. When one looks at the safety profile of nivolumab plus gemcitabine and cisplatin, it was really quite consistent with the established safety profiles. That is what one might expect using immunotherapy and that associated with chemotherapy, with 62% grade greater than or equal to 3 with the immunotherapy combination as compared to 52% with gemcitabine and cisplatin alone. Well, at the same ESMO 2023 meeting, additional data was presented with enfortumab vedotin. And we had already been excited about enfortumab vedotin. This is an antibody-drug conjugate that targets Nectin-4. It is conjugated to the microtubule disrupting agent monomethyl auristatin E by a protease cleavable linker. And in the EV301 study, which looked at patients who received platinum-based chemotherapy as well as immune checkpoint inhibition, patients randomized to enfortumab vedotin versus investigators' choice chemotherapy with a primary endpoint of overall survival demonstrated a significant improvement in survival outcomes for the enfortumab vedotin arm, here with a hazard ratio of 0.70, as well as progression-free survival with a hazard ratio of 0.62, higher overall response rate at 41% versus 18%. And this was the first study that really changed the landscape for patients who had previously received immune checkpoint inhibition and chemotherapy. In terms of treatment-related adverse events of special interests, we've needed to learn about how to manage enfortumab vedotin, the major issues being skin reactions, peripheral neuropathy, which is more commonly sensory but can be a motor neuropathy, as well as the potential for hyperglycemia, with skin and hyperglycemia side effects occurring earlier, whereas peripheral neuropathy tends to occur later. And with time, we have learned to manage with dose delays, reductions, sometimes the requirement for steroids when treating certain more severe skin reactions. And then we moved on to look at combinations with enfortumab vedotin, and most notably the combination of enfortumab with pembrolizumab, and the concept here being direct cytotoxicity, immunogenic cell death, and the potential enhancement of enfortumab-induced T-cell response by PD-1 checkpoint inhibition. And this was the EV302 study, again presented at the ESMO 2023 meeting. Here, comparing enfortumab vedotin and pembrolizumab versus chemotherapy with cisplatin or carboplatin and gemcitabine in previously untreated patients with a primary endpoint of PFS and overall survival. Here, 50% of the patients were cisplatin eligible. Close to 72% of the patients had visceral metastatic disease, with 22% of the patients having evidence of liver metastases. This data was really quite astounding. Here, the overall response rate at 68%, with close to a 30% complete response rate with EV and P, as compared to 44.4% and 12.5% complete response rate with chemotherapy. Here, looking at the Kaplan-Meier curves, the PFS benefit with a hazard ratio of 0.48 and overall survival with a hazard ratio of 0.51, with a median survival of 33.8 months with EV plus P and 15.9 months in chemotherapy, something we had not seen in the management of patients with metastatic urothelial carcinoma ever. When one looks at the efficacy among the subgroups, you don't need to see the details of the subgroups here. What you can see immediately is that looking at the progression-free survival and overall survival across all subgroups, the benefit was seen with enfortumab. When one looks at overall survival subgroup analysis, looking at cisplatin eligibility and those patients who are cisplatin ineligible, once again, the benefit is seen for enfortumab vedotin as compared with chemotherapy. Looking at treatment-related adverse events that are associated with enfortumab vedotin and pembrolizumab, similar to what one sees with enfortumab vedotin alone, perhaps more in the way of certain side effects with the addition, of course, of immune checkpoint blockade, as well as specifically looking at a higher incidence of rash and skin toxicity associated with the combination. This is, again, very exciting data looking at an earlier study, the EV-103 multi-cohort study, specifically looking in a cisplatin-ineligible population receiving enfortumab vedotin and pembrolizumab. And here is the Kaplan-Meier estimate looking at survival. And you can see here that 42% of the patients were alive at 5 years of follow-up, again, in a cisplatin-ineligible patient population, here receiving the combination of enfortumab and pembrolizumab. So here, looking at the EAU guidelines on metastatic bladder cancer, in patients who are eligible for combination therapy, the preferred management strategy based on the EV-302 data for patients with metastatic disease is enfortumab vedotin plus pembrolizumab. Again, it's been a very exciting time with the development of the EV antibody drug conjugate. There have been other antibody drug conjugates that are also under active investigation and many trials that have presented. This is one, sacituzumab govitecan. This is an ADC that targets TROP2, which is an epithelial cell surface antigen that is highly expressed in urothelial carcinoma. And its payload is SN38, or the active metabolite of irinotecan, which of course is the topoisomerase I inhibitor. I'm not going to go into all of the cohorts of this TROPHY-U01 study. It's a multi-cohort study here looking at patients who progressed after prior platinum-based chemotherapy and checkpoint inhibition with a primary endpoint of overall response rate. Here, the response of 27% with a median progression-free survival of 5.4 months and a median overall survival of 10.5 months. The toxicity is what one would expect with topoisomerase I inhibition, specifically myelosuppression, neutropenia, and febrile neutropenia. And based on this data in the States, the FDA granted an accelerated approval to sacituzumab govitecan. Unfortunately, the randomized phase 3 TROPICS-04 study, designed very much like the EV-301 study, here compared in patients who had previously received platinum-based chemotherapy as well as checkpoint inhibition with anti-PD-1 or L1 therapy, sacituzumab as compared to the treatment of physician's choice with chemotherapy, with a primary endpoint of overall survival. And this study was, again, unfortunately, a negative study. Sacituzumab did not show a significant survival benefit. And in fact, there was more in the way of treatment-emergent AEs leading to death in the sacituzumab arm as compared to the physician's choice of chemotherapy arm, specifically as related to issues with myelosuppression and febrile neutropenia. Again, one of the important side effects that we see with topoisomerase I inhibition. With this, that accelerated approval in the States was withdrawn. HER2 has been an important potential target in urothelial carcinoma for some time. This is data from Memorial Sloan Kettering Cancer Center looking at the expression of HER2 by immunohistochemistry in urothelial carcinoma. Here, 2+3+ in over 50% of tumors that were studied. And there has been an agent, trastuzumab deruxtecan, another antibody drug conjugate using deruxtecan, a topoisomerase I inhibitor, in the DESTINY-PanTumor02 phase 2 trial for HER2 expressing tumors, here with a cohort of patients with bladder cancer, revealing that in the 3+ patients, tumors, revealing a response rate of 56% and a promising progression-free survival of approximately 7 months, as well as overall survival with a median of 12.8 months. Again, drug-related treatment emergent adverse events that were seen consistent with topoisomerase I inhibition with myelosuppression. There's some nausea and fatigue. And this data generated an accelerated approval in the States with a tumor-agnostic approval for trastuzumab deruxtecan. There's a lot of excitement with other ADCs. This is disitamab vedotin here, an ADC targeting HER2 with the monomethyl auristatin E payload, similar to enfortumab vedotin. Multiple abstracts and papers that have been published here looking at disitamab vedotin in HER2 2+, 3+. Here, a response rate of 50%. In the 1+ group, activity with a response rate of 26%. And here, a median PFS of close to 6 months and a median overall survival of 14.2 months. Disitamab vedotin has been looked at in combination with the anti-PD-1 therapy, here with toripalimab, as well as with pembrolizumab, generating responses in over 70% with this combination, very similar to what we have seen with enfortumab and pembrolizumab. And I think there's a lot more to come when we're thinking about targeting HER2 in this disease, and specifically with the ADC disitamab vedotin. We have targeted agent in treatment of metastatic urothelial carcinoma. This is erdafitinib, targeting FGFR-altered tumors in patients. This is data looking at this agent in patients who receive greater than or equal to 1 line of platinum-based chemotherapy. Response rate of 40% in this phase 2 trial, promising time to event endpoints, and ultimately a phase 3 study that had 2 cohorts, one looking in patients who had received anti-PD-1 as monotherapy or as combination therapy, comparing enfortumab with chemotherapy, and a second cohort looking at erdafitinib as compared to pembrolizumab. Cohort 1 did in fact demonstrate an improvement in survival with a hazard ratio of 0.64. However, cohort 2, when compared to pembrolizumab, did not in fact generate an improvement in survival outcomes as compared to pembrolizumab. So again, back to the EAU guidelines on metastatic bladder cancer. What do we do for later line options of therapy with all of these new strategies in the first line setting? The answer is very complicated, and it looks sort of like this. There has been some recent data presented at the ASCO 2025 meeting looking at the question of platinum-based chemotherapy after enfortumab and pembrolizumab, again, in a retrospective cohort of patients, but with at least some promising response rates of about 50%. Here, median PFS of 4.6 months and a median overall survival of 11 months. So perhaps representing at least a benchmark for what we can use in the design of clinical trials. And so what is the answer? The answer is, of course, clinical trials. And we desperately need to get answers to the question of what and how we treat patients who have progressed after our first-line therapies. And with that, thank you for the opportunity to present, and I'm happy to take questions.
So thank you, Matt, for this excellent presentation. I have one question, because what do you think is the current role of maintenance avelumab and the current role of, for example, the combination of nivolumab with gemcitabine and cisplatin in the light of that groundbreaking results of that EV302 trial?
Thank you for the question. Yeah, I think that there's very little role, frankly speaking, for the use of those other regimens. I mean, I think you can envision a scenario perhaps where a patient may have significant underlying peripheral neuropathy, and therefore one might consider the use of gemcitabine and carboplatin, which is less of a neurotoxin as compared to cisplatin with maintenance of nivolumab. Again, I think that these are situations that we're not coming across very often in our clinical practices. And I think with regard to gemcitabine and cisplatin and nivolumab, again, perhaps patients who have very poorly controlled diabetes, for which there could be a problem with hyperglycemia with enfortumab. But I think you could also create a reasonably cogent argument that using cisplatin with the requirement for steroids might also be an issue in those patients as well. So I think that excellent question with not an entirely clear answer, at least yet, but I think enfortumab vedotin clearly the winner here with pembrolizumab.
Yeah, really groundbreaking results, that trial. Thank you, Matt. Then we go on with Richard. Richard, you will dig into future perspectives in systemic treatment for muscle-invasive bladder cancer. The floor is yours.
Yes, indeed. I will try to look into the crystal ball, what is going to happen in the very near future. And so I was asked to give an overview on the current trials for muscle-invasive bladder cancer. So I will not focus on metastatic disease, but this will be about muscle-invasive bladder cancer. And therefore, here are my disclosures. I think there are 4 important topics that I would like to cover. First of all, I will show you that there will be more perioperative trials with chemotherapy and checkpoint inhibitor combinations, very similar to the Niagara trial that you have seen presented by Professor Lorch. I will show you the very interesting perioperative trials with checkpoint inhibitors and antibody-drug conjugate combinations. I will discuss trials integrating ctDNA, which are very interesting to look at, and I think they might answer some important questions. And finally, something that is currently the flavor of the day is bladder-sparing approaches. So we'll go one after the other, and in the end, we will have some time for questions. First of all, start with the, I would say, easy trials. Here are 2 studies that are very similar to the Niagara trial, investigating the use of perioperative chemo plus immunotherapy. They are indeed very similar. Instead of durvalumab, the ENERGIZE study uses nivolumab as a checkpoint inhibitor. Again, this is before and after the radical cystectomy, so it's really a perioperative approach. And the KEYNOTE trial is using pembrolizumab as a checkpoint inhibitor. Other than that, the studies are really very similar to Niagara. They include similar patient population. They have to be cisplatin eligible. They have mainly urothelial histology, or they are T2 to T4A tumors. And the primary endpoint is event-free survival. And you will see that in these trials looking at perioperative treatment options, event-free survival is the primary endpoint in all of these trials. Of course, also secondary endpoints will be investigated, including overall survival and pathological complete remission rate. What will be the impact of these trials in the near future? I will think that most likely the results will turn out to be fairly similar to what we have seen with the integration of durvalumab in the Niagara trial. So I will not think that the results of these studies are really going to change much, since this is a very same principle. Certainly the use of checkpoint inhibitors in this neoadjuvant and adjuvant setting will impact the use of checkpoint inhibitors if these patients become metastatic later on. The problem there is, and this is already now the case, if patients have received adjuvant immunotherapy, we have no real good data to distinguish and to decide about the later line treatment. And this will be a theme that goes through all of these trials. What will we do if the patients relapse later? So here, now let's go to the next option, which is the combination of immunotherapy and antibody-drug conjugates, namely enfortumab vedotin, the Nectin-4 ADC that you have just heard Professor Milowski talking about in the metastatic setting with very, very exciting results. And this has now become the standard of care for metastatic disease. Now, the obvious question is, will it work in the muscle-invasive setting as well? And the trial design is similar to the trials you have seen with chemotherapy and checkpoint inhibitors. So it will be enfortumab combined with pembrolizumab for 4 cycles, so 12 weeks of treatment and follow invasive for 5 cycles. 1 year. This is compared to gemcitabine cisplatin as a neoadjuvant treatment and observation as an adjuvant treatment. Now, obviously, we can discuss whether this is still the standard of care these days, since we have seen overall survival benefit with the integration of checkpoint inhibitors. And this will be expect results very soon, still at the end of this year. This is for cisplatin eligible patients. I think that's very important, primary endpoint event-free survival, but a very, very similar trial is being performed for patients who are cisplatin ineligible. So here the comparator arm is no treatment, so surgery alone, compared to EV Pembro before and after the surgery, or in the case of EV303, compared to pembrolizumab as a monotherapy, so without the ADC, then surgery, followed by pembrolizumab afterwards. There is a second trial in this very same patient population of cisplatin ineligible patients, called the Volga study. They don't use pembrolizumab as a checkpoint inhibitor, but durvalumab, and in addition, tremelimumab as a CTLA-4 checkpoint inhibitor in one of the 3 arms. One arm is durva and enfortumab only, and one is no treatment again, which is the control arm. Again, the primary endpoint is event-free survival. I think Volga is very interesting since it compares CTLA-4 plus PD-1 checkpoint inhibition plus enfortumab, and the PD-L1 and enfortumab compared to no treatment. So I think these 2 trials will certainly shape what we will be doing. And this, if we look into the future here, I think in the cisplatin eligible patients with EV304, integrating the combination of enfortumab pembro in the perioperative setting, there will be this discussion since the comparator arm in the study is chemo neoadjuvant only. However, if the scale of benefit is high, so if we will see a very much improved event-free survival, possibly or probably very high pathological complete remission rates, this might very well become the new standard of care. And again, we have this major impact on later line therapy. So if we used ADC IO in the first line muscle invasive setting, what do we do when the patient become metastatic? This will be even more difficult. For cisplatin ineligible, I think both trials are very likely to be positive since they compare to surgery alone. I think they're very likely to become the new standard of care, and they will likely replace adjuvant treatment only. Again, here we could discuss, should the patients who have surgery alone receive adjuvant immunotherapy? This is not included in the studies, as you have seen. Again, there will be a major impact on later line. And I think the most important is written in the bottom of this slide. If we see very high PCR rates, this might support bladder intact approaches, which we will see later, and several trials are being started and will probably shape what we will be doing in the future very soon. So let's look at ctDNA. You already heard about ctDNA from Professor Lorsch. Certainly, ctDNA has been shown to be a prognostic marker. Everybody talks about ctDNA, and we have seen this post hoc analysis of the adjuvant trial in Vigor-010, where atezolizumab was compared to no adjuvant treatment. And you can clearly see if you have ctDNA negative disease after radical cystectomy, you're going to do much better than if you have ctDNA positive disease. The benefit for atezolizumab is in this study, and this is post hoc, only seen in ctDNA positive patients. So you might think that maybe ctDNA is predictive. However, if we look at the prospective analysis of the Niagara trial, so chemotherapy, checkpoint inhibitor, followed by surgery, followed by adjuvant checkpoint inhibitor, it doesn't matter whether you have ctDNA negative or ctDNA positive disease, everybody benefits from the addition of durvalumab. And actually, the benefit is even higher in patients with ctDNA negative baseline disease. So I think this puts a lot of questions on whether ctDNA may really be a predictive marker. And I mean, what are the questions here? ctDNA, if it's negative, does this allow us to omit adjuvant treatment after radical surgery? Or can we wait until the ctDNA is positive? And the other question is, if the ctDNA is positive, do these patients need further intensification of the adjuvant treatment? There are 2 studies looking into these questions. The first one is in Vigor-011. Again, here we hope to see results fairly soon. Patients were included after radical cystectomy if they had still T2 disease or higher. If they were within 24 weeks since the radical cystectomy, they then underwent serial ctDNA testing over the course of 12 months, initially every 6 weeks, then every 12 weeks. If ctDNA turned out to be positive, they were randomized 2-to-1 to receive atezolizumab for 1 year or placebo. If ctDNA remained negative, they simply had observation. I think there is an issue in this study, obviously, randomizing patients with ctDNA positive disease to placebo. This is not something that we would consider as a standard of care anymore. Also, this is not really an intensification of ctDNA positive patients, but simply one group gets the treatment, the other doesn't. And so I think the trial that to me is more interesting and more modern is the modern study. Actually, here, similar patient population as in Vigor-011. After radical cystectomy, they receive a ctDNA test. And remember, this is always a test that is based on the patient's tumor. So this is personalized ctDNA. This is not just fishing for any circulating tumor DNA in the patient's blood. If the patient is ctDNA positive, they are in cohort A, these patients. They receive either standard adjuvant nivolumab for 1 year or an intensification of nivolumab plus the LAG-3 inhibitor relatlimab, again for 1 year. The patient starts with ctDNA negative disease. They are randomized again to the standard, which is nivolumab for 1 year, or else they have serial ctDNA measurements very similar to in Vigor-011, and they're only started nivo if they turn into ctDNA positive disease. So I think this trial will be better able to answer our questions, whether we can omit adjuvant treatment in the ctDNA negative or whether we need to escalate treatment in ctDNA positive patients. The primary endpoints are a bit different for the 2 cohorts. So I very much hope we will soon see the results of this study. Now, what does this tell us? I think so far ctDNA is not really ready for clinical use, certainly not for taking any predictive decisions. I think these 2 trials will put ctDNA on the clinical map, but it's too early to call as yet. Some questions arise, especially you have seen the studies incorporating antibody-drug conjugates into the treatment setting. Are these trials still valid if you use these novel neoadjuvant therapies? What about changing from a schedule that was proved to be positive in a phase 3 study based on the modern trial, for example? I think these are unanswered questions that will need to be discussed in the future. Finally, I would like to briefly touch on bladder-sparing approaches with systemic treatment alone, systemic plus intravesical therapy, or systemic treatment plus radiotherapy. I think most of you will have seen the results of this study by Matt Golsky, where patients received neoadjuvant chemoimmunotherapy, and if they had a clinical complete remission, which was defined by CT, MRI, bladder, cystoscopy with biopsies and urine cytology, they went on to just have surveillance rather than local treatment. It was a total of 76 patients, and 43% achieved the clinical complete remission. And of these, 23 remain without cystectomy and still in CR. So overall, 30% of the patients included could avoid to have the bladder operated or irradiated. So based on this, one of the trials that is going to investigate this question is the NeoBlast study from Peter Black in Vancouver. The patients receive standard of care neoadjuvant therapy, which is not predefined. If they achieve clinical CR, which is defined very similarly to Golski's trial, but also includes ctDNA measurement, which needs to be negative. So if they have clinical CR, they are randomized to either surveillance or local treatment with surgery or chemoradiotherapy. If they have no CR, they get local treatment. I think the important step here will be, will patients be willing to undergo randomization between surveillance and local treatment, since many patients will probably opt for surveillance rather than local therapy. So there will be a phase 2 pilot study to see if this is feasible or not, and I'm very curious to see the first results. Primary endpoint here is metastasis-free survival at 2 years. The first study to look into the combination of systemic therapy and intravesical treatment is Sunrise-2. Probably all of you have heard of TAR-200, an intravesical Brexu device that releases gemcitabine, and that is changed in this study every 3 weeks for the first 4 months and then every 12 weeks, which is combined with a PD-L1 inhibitor, acetrelimab, intravenously. So essentially only intravesical and systemic therapy. And this trial, Sunrise-2, compared this approach to standard of care chemoradiotherapy. This was for patients who were ineligible or refused radical cystectomy, and the primary endpoint was bladder intact event-free survival. This was a big hope that maybe this would be a way forward. Unfortunately, a press release in October 24 told us that the trial has been discontinued, so this approach is not further investigated. However, I still believe that intravesical therapies combined with systemic treatment can carry interesting outlook, but not this combination here. Finally, the obvious is to do radiotherapy, chemotherapy, so chemoradiotherapy, and include a checkpoint inhibitor. And this is investigated in KEYNOTE-992, again, a phase 3 placebo-controlled study of chemoradiotherapy, standard of care combined with pembrolizumab or placebo, primary endpoint being bladder intact event-free survival. And this trial has finally accrued, and we hope to see the results soon. So what will be the impact of these bladder-sparing approaches? I think systemic treatment only might be preferred by patients, so not needing to undergo local therapy, whether this is surgery or radiotherapy. Certainly, we will see improved induction treatments, and they are likely to alter the landscape. And I think this bladder intact approach might become reality outside of trials, which is somewhat dangerous because we don't really know how to follow these patients up. I think the standard of care should still be systemic treatment and local therapy, but this is a point for discussion. The integration of intravesical treatment I mentioned, I think this is a first step that did not work, but we will see further approaches, and whether the checkpoint inhibitor plus chemoradiotherapy will improve outcome needs to be shown. So what are my take-home messages for you? I think it's 3 important messages. First of all, systemic treatment really is an integral part of the treatment of muscle-invasive bladder cancer. I think we have seen that by now. We will probably see chemo-free possibilities. We will see more individualized treatments. I did not show you the HER2 approaches because so far no phase 3 trials are running, but they are coming. We will have biomarkers. This is ctDNA. This might be FGFR mutations. This might be HER2 approaches. This will help us to choose the drugs. This will help us to maybe de-escalate treatment or escalate treatment. And then finally, bladder sparing. I definitely think bladder intact is something that is wished for by the patients, and we will need to see how we can achieve that. And with this, I give back to Tony. Thank you very much.
Thank you, Richard, for this excellent overview. One question. The choice of chemoimmunotherapy combinations in the perioperative setting have an impact on the treatment of metastatic bladder cancer. But what about the combination of enfortumab vedotin plus pembrolizumab? Does it still make sense in patients who develop metastasis after receiving perioperative immune checkpoint inhibitors? What do you think?
Well, I think if a patient has received checkpoint inhibitor as part of a perioperative regimen, whether this is neoadjuvant, adjuvant, or adjuvant alone, this always carries the question, if this patient relapses, can we give IO after IO? So checkpoint inhibitor after checkpoint inhibitor. And the question is, we don't know. If we look into other diseases, such as a renal cell carcinoma, it doesn't really work. So if you had progression on IO, you are less likely to respond. Even in melanoma, you are less likely to respond to checkpoint inhibitor after checkpoint inhibitor. In clinic, what we currently use, I think, is an arbitrary threshold of saying, well, if more than 1 year has passed since we stopped the adjuvant treatment or the perioperative treatment with a checkpoint inhibitor and the patient has a relapse, I think we would consider to treat this patient with a checkpoint-based combination such as Pembro-EV. If it's less than 6 months, I think the patient is really checkpoint inhibitor refractory and he should not get any checkpoint inhibitor. And then this would be a candidate for enfortumab vedotin single agent or for platinum-based chemo if he has never seen any platinum-based chemotherapy. And with the patients who are between 6 and 12 months, I don't know, nobody knows anyway. I think this is a very individual decision based on the patient's performance status, based on patients' and physicians' preference. And I hope we will see some results on that, but it will take a while.
So in an ideal world, we would have to wait 1 year in between 2 schedules with checkpoint inhibitors.
I mean, the hope is if, say, the EV304 study is being positive and we will have an event-free survival at 5 years, which exceeds 80%, we will see much less of these patients. This will be a completely different world. If we look at the adjuvant data that Anja showed with just adding Nivo or Pembro after surgery, the relapse rate is still 30 to 40%, so it's much higher. And I think these improved perioperative regimens, they will hopefully cure more patients and we will have less of these issues.
Okay, thank you. Then for time's sake, we have a few questions from the audience. And the first question was, what about immunotherapy patients who refuse cystectomy and are candidates for trimodality treatment? Anja, can you reflect on that question, please? So is there a place for immunotherapy in patients who refuse cystectomy and are actually candidates for trimodal therapy?
Actually, we don't have the data so far. Richard Katoma presented that there was a trial when that has given only a systemic treatment, but so far, if you did trimodal therapy to add adjuvant immunotherapy, we don't have the data, and I wouldn't do that actually.
Some other suggestions, Richard, Matt?
Well, maybe if I can chime in here, adjuvant checkpoint inhibitors after chemoradiotherapy have never been tested. But if you think of treating a patient with chemoradiotherapy, you should also think about neoadjuvant chemo. I mean, it's still, the problem is systemic. The patients will die from systemic disease. And really, if a patient is fit for cisplatin-based chemotherapy, but he does not want to have the surgery and says so right from the start, I really believe that neoadjuvant chemo, cisplatin-based standard, like 4 cycles of cisplatin gemcitabine is beneficial if they go on to have chemoradiotherapy. But there is no phase 3 data out there, and it's done very different in different centers.
And if I may add, I think this question was kind of the question, if you have a patient going or starting with Niagara and then refuses resection, you would maybe do local treatment with radiotherapy. And then the question occurs, would we give then the durvalumab adjuvant as adjuvant treatment if we compare it to resection? I wouldn't do it because we don't have the data. So because there are patients, they start with chemoimmuno, then they say, I want to preserve my bladder. They get local radiotherapy because, to my view, you need local therapy kind of for the time being. And then the question raises, durvalumab then for 1 year or not? And in those cases, I said, we don't have the data, I don't do it. I don't know what Matt and Richard think about that.
Yeah, no, I agree. I don't think that there's any clear rationale at present to pursue that approach. I mean, I think we just need to be really careful about these studies and how they're designed to spare the bladder. I mean, truth be told, we do have a bladder sparing approach. It's referred to as trimodality therapy, and it's something that we've had for many years. I think looking at systemic therapy alone, we really need rigorous methodology to understand whether or not a bladder can be preserved. Help from our urologists in doing biopsies. We need biomarkers, perhaps ctDNA, perhaps things like urine tumor DNA, as well as imaging modalities, perhaps MR, that are being used in some protocols, and putting all of this information together to be able to best select those patients who can undergo these type of bladder sparing approaches.
Yeah, yes, definitely agree. I think it's really dangerous to just jump ahead of the train. This should be done within trials, preferably, and outside it's not the standard of care at all. I mean, this is very small single-arm phase 2 studies so far.
Yeah. Then another question, the last question: how might biomarker-driven treatment personalization reshape the future of systemic therapy in muscle-invasive bladder cancer?
Well, I tried to give a little bit of an answer. I think the ctDNA is something that we need to look out for. Personally, I believe it's too early to use it in clinic outside of studies, but I'm curious to hear the thoughts of Anja and Matt. And then I'm pretty sure that HER2 is going to come. I think this is being very interesting. Since, as has been shown, HER2 2+ and 3+ is 50% or more of the patients. The first phase 2 trials look very promising, combining HER2-based ADCs with checkpoint inhibitors. I think this will be the 2 biomarkers that I see have a chance of changing something in the near future.
Or HER2 and ctDNA.
I would agree, actually, and ctDNA, to my view, is not for daily clinical practice yet. As I said, we know it's prognostic, but that's it for the moment. So it might become a selection criteria in the future to select those patients who need local treatment or adjuvant treatment, but it's too early to implement that in our patient that we see tomorrow in our practice. And for HER2, I think testing is very important. I do it already, or I think we all do it, Matt and Richard. If a patient is in a relapse situation and needs salvage treatment, this is an option, a good option. Yet it's not reimbursed. It's difficult to get it. But the take-home message is we have to test. We have to test for FGFR. We have to test for HER2. I think that's important to do. Actually, when we have patients relapsing after treatment of metastatic disease. So there are not many options, but that could be one good option. And actually in my clinic, I have very good results with remissions. We asked the health insurance companies, and in those patients where we performed it, they really did quite well, actually, and are in a remission so far. So yeah, that's the future, I think.
Okay, for time's sakes, I want to thank you all for joining us today, especially given the heat wave currently is sweeping across Europe. A special thanks, of course, to the professors Anja Lorch, Matt Wilowski, and Richard Katamas for their clear and meaningful, insightful presentations. And of course, a very big thank for Crystal for coordinating this webinar so smoothly. I wish you all a pleasant evening and a wonderful summer ahead. Thank you for joining. Thank you.